Good afternoon, and welcome to the AMCP webinar titled Access, Affordability, and Outcomes, the Value of Managed Care Pharmacy, presented by Berkeley Research Group. Thank you for taking the time out of your day to join us. My name is Tyler Thorne, and I am the Senior Coordinator of Government Affairs at AMCP, and I will be your moderator today. This presentation will be recorded and made available to members on AMCP Learn. This webinar is developed and presented by Berkeley Research Group. The content of this webinar and opinions expressed by the presenters are those of the presenters, and they do not necessarily reflect the opinions of AMCP or BRG. I'd also like to review a few housekeeping items to better assist us for the question period. At any time during this presentation, we encourage you to type your question in the box in the top right corner of the screen, which will only be viewable to the panelists. Our presenters will be monitoring your questions during the webinar and will try their best to answer them, so please feel free to submit your questions as they come up. If there are any remaining questions at the end of the presentation, we will try our best to answer them. Please note that some of the questions may not be asked due to regulatory or compliance reasons. If your question was unanswered, we will try our best to present any answers offline. Our first speaker today is Heather Bates. Heather is a co-author of the Access, Affordability, and Outcomes report and serves as a managing director with BRG in Washington, D.C. Heather provides consulting and analytical services to healthcare and life science clients and their counsel regarding economic, regulatory, damages, and discovery issues. Our second presenter today is Susanna Leith. Susanna is also a co-author of the Access, Affordability, and Outcomes report and is an associate director with BRG's Health Analytics practice. Susanna provides consulting services to pharmaceutical companies, pharmacy benefit managers, and their legal counsel, and has advised payers, hospitals, and medical device companies. Now, I will turn it over to Susanna to begin our presentation.
Great. Thank you, Tyler. Welcome, everyone. We're excited to talk to you all today about managed care pharmacy. I'm just going to set the stage for the rest of our webinar. We're going to start with the importance of managed care. We're then going to talk specifically about the managed care pharmacy tools that were the focus of our report. And we'll talk in detail about what those tools are, why they're important, and the impact on patients and costs that those tools have. We will then examine a comparative analysis that Heather and I performed of Medicaid data in the hepatitis C class of drugs to look at spending by fee-for-service compared to managed care programs and some of the cost savings that we note were derived by managed care plans. We'll talk in detail about that analysis. And then, as Tyler mentioned, we'll leave some time at the end, ideally, for any questions that haven't been answered up until that point. Okay, so we're going to start off with a poll question just to get a better sense of our audience. So what best describes your professional affiliation? And please select one. Are you affiliated with a pharmacy, a PBM, a health plan, a healthcare provider, or some other organization? Okay, so some results are coming in and we've got a mix of organizations, so welcome everyone.
Great. Thanks, Susanna, and thanks everyone for being here. We're excited. We were excited to do this report and excited to talk to you about what we found today. So I'll get us started if we move on to the next slide. This is probably not a surprise to anyone on the phone, especially with having so many folks coming from PBM and health plans, that the access to prescription medication and the affordability of that medication is really available to those who have insurance. And so the lack of insurance leads to lower utilization and higher out-of-pocket spending for patients. So looking at the IQVIA analysis on the right or the left-hand side of the screen, the green line there shows you the out-of-pocket costs to patients that do not have insurance. And then everyone at the lower part of that, of these graphics, are those who have insurance and they're paying their out-of-pocket costs for products, whether they're covered by commercial, Medicare, or Medicaid. And what's interesting is this analysis that looks at 2016 through 2021. In all categories of drugs, brands and generics, the out-of-pocket costs for members with insurance went down over that time period. So again, showing really the impact of managed care on bringing down costs to patients and access, giving them access to medication. On the right-hand side, we looked at how patients react to costs of medication and what percentage of them reduce or stop taking medications or fail to refill medications because of the high drug costs. And not surprisingly, there's a significant percentage of uninsured patients that don't take their medications due to costs. But there's still a material number of patients with private or Medicaid insurance who are doing the same. So to us, this indicates there's still room for improvement on reducing costs to those members and ensuring adherence with their medication regimen. So let's go to the next slide. This slide probably won't be surprising to anyone on the phone. The cost and the spending on prescription drugs has grown significantly since the 1990s. So net spending on drugs was about $40 billion in 1990, and now we're close to $380 billion by 2021. And so CMS is projecting that prescription drug spending is going to grow annually from now until 2030 at about 5% per year. And that's going to be driven by new and innovative therapies, biologics, continued focus on products in oncology, and also those with orphan drug status. Now, interestingly, as the percentage is going to keep growing, prescription drug share of total healthcare spending is actually projected to remain pretty steady at 8.4% by 2030, which is the same as it's been since 2020. And another interesting finding, CMS is projecting that the consumer share of spending of that, $380 to $400 billion is expected to actually drop by 2030. We're currently at about 13%. And that's expected to drop to 10% by 2030. And that's probably in part driven by the Inflation Reduction Act, Part D redesign, which is going to cap beneficiary out-of-pocket spending, but also some of the tools that we're going to talk about today that managed care plans really use to help lower costs to patients and make sure they're getting access to clinically appropriate and affordable medications.
Great. So again, as many of you may be aware, it's very common for an individual's pharmacy benefit to be provided through a managed care organization. So on the chart on this slide, what we're showing is that our estimate is that in the Medicaid population, 75% of beneficiaries are getting their prescription drug benefit through a managed care organization, with that remaining 25% coming directly from the government through a fee-for-service plan. In Medicare, we're estimating about 78% of beneficiaries get their prescription drug coverage through managed care, and that's because that remaining portion of Medicare beneficiaries may not get their drug benefit through a Part D plan. They either don't have coverage or have coverage through some other means. And in the commercial population, it's essentially all lives are being covered through managed care organizations. So as we are all probably familiar, managed care pharmacy really does touch on so many individuals' lives in the United States through the prescription drug benefit. But what's interesting about this chart is that in both Medicaid and Medicare, you can see that there's still room for those percentages to grow and for more lives to be brought under the purview of managed care plans when it comes to that prescription drug benefit, and for the tools of managed care pharmacy that we're going to discuss in more detail to reach more people through that means. And I'll also note before we move on to the next slide, the Medicaid portion of covered lives that's in managed care just in general has been rising very significantly over the years. That percentage was closer to 56% in 2000, and it just keeps increasing each year. So more and more states are recognizing that managed care can deliver appropriate clinical outcomes at cost savings, and they're taking advantage of that and putting more and more of their Medicaid population in a managed care plan. Okay, please proceed. Okay, so now I'm going to talk about the 5 key areas of managed care pharmacy, all of which are working toward that goal of improving patient outcomes while making the most of limited healthcare resources. And as I talk through each of these areas, you'll probably notice that a lot of them intersect with one another, and that's really on purpose. It demonstrates how managed care pharmacy practice, each area is intended to complement and support the other areas, all working together toward that goal of promoting better outcomes while managing costs. So I'll start with pharmacy benefit design and implementation. And this really comes down to ensuring access to care by defining what is covered and where it is covered. So in the context of the drug benefit, this obviously involves deciding what products are going to be covered on a plan's formulary, and then developing a network of pharmacies, retail and community pharmacies, mail order pharmacies, and specialty pharmacies where patients can obtain those drugs at the lowest cost, both to them and to their plans. Under the umbrella of clinical programs, managed care organizations implement coordinated care programs that may be targeted at patients with specific conditions. And that can involve organizing a patient's care across multiple providers, ensuring proper communication between a patient and their providers, between multiple providers of the same patient. It also encompasses drug utilization reviews, which we'll get into a bit later in this presentation, as well as the completion of medication therapy management, which is another topic that we're going to talk about in more detail. But clinical programs in general are aimed at helping to ensure that patients understand the medications they're taking and why they're taking them, the risks that might be associated with them, and also helping to alert patients to potential safety concerns with their drug regimens and getting ahead of those and avoiding any adverse outcomes. The next area I'll discuss is promoting affordability, and this one is just so important given all that Heather alluded to about the rise in prescription drug costs. From a managed care pharmacy perspective, this involves reducing risk for patients, employers, and other payers by managing overall costs. And managed care organizations have a variety of mechanisms through which they help to manage costs. The creation of formularies, the use of pharmacy networks, the use of maximum allowable cost pricing when it comes to generic drugs to ensure that they're not paying too much for those products, negotiations with manufacturers that I'm sure many of you all who come from a PBM are very familiar with, and then use of utilization management and other tools. And all of these tools work together to protect against misuse, overuse, abuse, and fraud. And this is, a topic that is becoming more and more used, but under promoting affordability, there's also the idea of value-based care arrangements and negotiating with pharmaceutical manufacturers based on clinical outcomes. The fourth area of managed care pharmacy is quality and safety program management. So these programs are designed to ensure that pharmacies are delivering safe and efficient care to patients, and managed care organizations have a variety of quality metrics such as timely prescription fills, rate of dispensing errors, and general monitoring of the availability of drugs at a pharmacy to ensure that the pharmacies and their networks are meeting quality standards for patients. It also involves the reporting of Medicare Advantage and Medicare Part D star ratings, which is a measure that patients can use when picking a plan to compare the quality of one plan to another. And the last bucket is formulary and medication utilization management. So that's determining which medications are going to be included on a plan's formulary, and then applying drug management strategies such as prior authorization and step therapy to ensure appropriate use of those medications, and that patients who need to access medications have those available to them. And then within this is also tracking new and developing medications and treatment protocols, and ensuring that a plan's design and its formulary are up to date and include clinically appropriate new products. And as we see more and more of those innovative products coming to market that come with those very high price tags, it's more important than ever to ensure appropriate medication use to ensure continued access while managing costs. Okay, we can proceed.
Okay, so in our study, we talked about, if we go to the next slide, we talked about some very specific tools that managed care pharmacy uses within the 5 areas that Susanna just described. So today we'll talk about those: prior authorization, step therapy, drug utilization review, medication therapy management, and then formulary design and management. So let's go on to the next slide and we'll jump into prior authorization first. So our research found that when you look at enrollees in commercial plans, the vast majority of them are in plans where fewer than 10% of the products are subject to a prior authorization. But when you contrast that to Medicare Part D, it's a much higher percentage of the covered products that are subject to PA. And in fact, that Part D percentage has really grown significantly since the outset of the program. Now, in terms of the impact of prior authorizations, there was an interesting study by AEI earlier this year, and they looked at prior authorizations in Medicare Part D specifically, and they found that overall, prior authorizations reduce the use of the drug that's subject to a prior auth by 25%. So a quarter of the individuals who tried to get a product that was covered by a PA didn't end up getting that product, got something else, or didn't get treatment at all. And then second, they found that overall spending by Part D was reduced by 3% due to prior authorizations. So given the spending in the Part D program, that's a material amount of money. And translated into beneficiary years, that worked out to about $96 per beneficiary year. Now, AEI did make the point that they weren't able to measure the impact on patient health outcomes, and so that's an area for additional study. Contrasting to that study, there was also earlier this year a survey that the AMA did of physicians. They indicated that they surveyed about 4 in 5 physicians, and that the majority of those said that authorization controls lead to unnecessary waste and avoidable patient harm. 65% of the respondents said that resources were diverted to ineffective initial treatments or more office visits, and 46% said PA policies led to urgent or emergency care for their patients. So clearly we have some tension here between the PBMs, the health plans, the employer groups that are putting in PAs to make sure that there isn't misuse of products or use of products that are no more clinically effective than less expensive products. And on the other side, the providers that write prescriptions for their patients and then have to deal with the burden of working through the prior authorizations. So I think this really presents some opportunities in the industry, specifically studying how we could improve the prior authorization process. You know, can we reduce the administrative burden through more electronic processing? Could we use machine learning or AI to figure out, are there parts of the population that shouldn't be subject to a prior auth based on medical records or other demographics? But ultimately, we do need more robust analytics on the issue of patient impact of prior auths. And so that's something that will be interesting to follow to see if we can collectively start to improve this and reduce the tension between payers and providers around this particular tool in the industry.
Great. Okay, so another very common tool that many of you may also be familiar with is step therapy, sometimes referred to as fail first, and that's because it requires a patient to be treated with the least costly therapy first before moving on to a more expensive treatment option, and only after the patient has demonstrated that original therapy is ineffective. So again, the goal of step therapy is to identify the most affordable and effective medication for a patient, and extensive clinical research goes into the development of a plan's step therapy protocols. When done well, step therapy can help to steer patients to drugs that are safe and effective, and which cost significantly less than alternatives that just haven't demonstrated a superior clinical benefit. It's also important to note that while step therapy is a widely utilized tool, it's not required for all medications, and the extent to which it is applied varies by plan. So in writing our report, we looked at one study that examined commercial plan drug coverage policies for specialty drugs. Researchers in that study found that roughly 39% of commercial specialty drug coverage policies included step therapy, and on average, there were 1.5 steps required. However, when you looked at those 17 plans individually, the portion of policies that were subject to step therapy ranged anywhere from 20% for one plan up to 57% for another plan. There was also differences by disease area. So chronic migraine was one disease area that researchers in this study examined, and they found that 100% of policies relevant to that disease area included step therapy, whereas for multiple sclerosis, only 35% included step therapy. So while step therapy is a necessary tool in managing prescription drug costs, there are also similar critiques as what Heather mentioned about prior authorization in terms of the administrative burden that step therapy can place on providers and patients, and the possibility that step therapy could produce short-term cost savings, but could lead to higher spending overall, for example, if it leads to increased provider visits. There has been legislation at the state level, and in addition, at the congressional level through the Safe Step Act, which was reintroduced in 2023. And what that would do would be to require certain health plans to allow exemptions for step therapy protocols for various reasons. For example, if a patient is already stable on a particular therapy, or if the required treatments have previously been demonstrated to be ineffective for that patient. And so what I think is important to note here is while there is some concern that step therapy protocols are not always consistent with clinical guidelines, in our paper, we found research from the Institute for Clinical and Economic Review that studied this exact issue and found that step therapy protocols were consistent with fair access criteria 98% of the time. And that fair access criteria that ICER evaluated were as follows. Was the first step clinically appropriate for nearly all patients, and would it pose any greater risk of significant side effects? They looked at whether patients would have a reasonable chance to meet clinical goals with that first step therapy. They also examined whether failure on that first step and any potential resulting delay in beginning another therapy, whether that would lead to any long-term harm for patients. And they also examined protocols to determine that patients are not required to retry a first-line drug when they've previously had an adverse side effect or reaction to that, or an inadequate response. So when ICER evaluated those fair access criteria, looking at commercial plans, the VA, and several exchange plans, they found concordance with those fair access criteria 98% of the time. So, you know, again, there's this tension between patients and providers, and the health plans that are trying to manage costs. We all know that managed care pharmacy isn't practiced in a vacuum. It's not a static practice, and the field evolves to changing needs or in response to identified areas of improvement. So I think, again, step therapy is another area of potential study where there may be an opportunity to introduce greater flexibility in how protocols are implemented, and to hone in which patients and specific situations necessitate step therapy, whereas what other situations might it make sense to bypass step therapy.
Great. So let's move on to drug utilization review. So a standard definition of DUR is an authorized and structured review of prescribing, dispensing, and use of medications. So this is required in Medicaid statutorily, but it's also very widely used almost universally within commercial and Part D plans. And there's really three different types of DUR. There's prospective, which happens before a drug is dispensed. And typically these are algorithms that are incorporated into the claim adjudication process. And prospective DUR identifies potential issues of clinical misuse, a drug disease contraindication, a modification of the drug dosage that needs to occur, or a drug-to-drug interaction where if two or more drugs are prescribed, they could either cause adverse events or their intended effects are impacted by the prescription of both of them. Another example would be a drug-to-patient precaution related to the patient's age or gender or pregnancy, for example. And then finally, the prospective DUR can identify formulary substitutions on the front end, either a therapeutic interchange or a generic substitution that could lower costs. Then second, there's concurrent DUR. Concurrent DUR is one that's performed during the course of treatment, and it really involves ongoing monitoring of the patient's drug therapy, the goal of which is to foster positive patient outcomes. Now, for concurrent DUR to be effective, it really needs to involve a complete and current record of the patient's medications and allergies. And so that often is difficult to achieve. And so you will typically see concurrent DUR happening more in institutional settings where patients are often receiving multiple medications, they're under close observation, and caregivers can perform periodic review of the patient records, of their medication, of their clinical status and improvement, and try to detect problems and improve their therapy and regimen over time. And then finally, there's retrospective DUR, which looks at the drug therapy after the patient has received the medication. And the goal here is typically to detect patterns in prescribing, dispensing, or administering products to target interventions, identify less expensive alternative therapies, and to prevent the recurrence of inappropriate medication use or abuse. So with that overview of DUR, we found that from the state Medicaid perspective, that the programs have estimated, at least back in 2017, an average savings of $57 million per year just based on the prospective DUR. So it'd be interesting to study going forward how either concurrent or retrospective DUR is not only saving money, but avoiding potential costs if those programs weren't put in place. So with that, I think we can move on to the next slide.
Okay, we're gonna throw in another poll question now before we dive into medication therapy management. What is your familiarity with medication therapy management? None, some, or very experienced? Okay, great. So again, we have a mix, but a lot of people kind of sitting in that middle bucket. So we'll dive into medication therapy management and talk about it in more detail. Okay, so medication therapy management, or MTM, again, is a program that is required in Part D. It's not exclusive to Part D, but it is required in the Part D program. And so the focus of our report was on MTM in Part D. And in the Part D program, MTM is offered to certain beneficiaries based on a set of criteria. So that includes beneficiaries with multiple chronic conditions, who take multiple drugs, or who have a high likelihood of high drug cost and spending. And medication therapy management involves a variety of different practices. One of the most important ones is the medication therapy review. And that's a process of collecting patient-specific information. So it's all patient-centered, assessing medication therapies to identify potential problems, and then developing a list of those potential problems and a plan to resolve them. So medication therapy review, there's actually two types of medication therapy review. There's the comprehensive medication review, or CMR. That is performed at least once a year for Part D beneficiaries that qualify. It's in real time, and it's either face-to-face or telehealth between a patient and a pharmacist or other healthcare professional. And during that CMR, the pharmacist will review the patient's medications, what they're currently taking, make sure that they're safe, that all of the medications that a patient is taking are appropriate and necessary. The pharmacist will answer the patient's questions about their drug regimen and discuss any concerns, really with the goal of making sure the patient understands what all they're taking, why they're taking it, that they know how to take it safely and effectively. The pharmacist could also discuss during a CMR whether there are lower cost alternatives that a patient could consider to help bring down the cost of their drug regimen. And then coming out of a CMR, patients will actually receive two documents. One is a personal medication record, which is a record of all of that patient's medications. Prescription, over-the-counter, dietary supplements, herbal products, whatever they're taking will be documented. And they'll also get a medication-related action plan, which is, again, a list of actions for that patient to take to ensure that they're taking their medication safely. So that might involve, a reminder to set an alarm to take a certain medication at a certain time of day if it has to be taken morning, noon, and night, for example. So that's the CMR. The other type of medication review is a targeted medication review, or TMR, and that is used more so for ongoing monitoring and is designed to address a specific or potential medication-related problem. So not as holistic as the CMR, but actually looking for potential problems and ways to avoid them or reduce risk. TMRs are performed quarterly, so CMR is performed annually, a TMR is performed quarterly. There are some other aspects to medication therapy management. The pharmacist might intervene when they identify a medication-related problem and may encourage the patient to follow up with their physician to change something in their drug regimen in order to solve those problems. As part of our report, we wanted to understand how is MTM impacting patients, both from a cost perspective and a clinical outcomes perspective. And we found a number of studies that demonstrate the benefit that MTM can have on patient outcomes. So in one study that targeted Part D beneficiaries with diabetes or coronary artery disease, where patients were not taking statins, but could benefit from doing so. Participants in the MTM group had a 65% greater uptake of statins compared with the group that didn't receive MTM services. And the study's authors estimated that because of that uptick in statin adoption, there could be avoidance of a cardiovascular event and the significant costs related to that event in terms of emergency department or hospital admission. In another study by researchers at Humana, they found that receipt of MTM services either through TMR or through CMR were associated with reductions in healthcare utilization. So again, avoidance of inpatient admissions or emergency department visits, as well as increases in medication adherence. So we found very positive results about medication therapy management and the impacts that it has on patients.
Great. And I think one other thing we found before we jump into the poll questions is there's still really room for expansion of MTM and more involvement from members of the managed care pharmacy community. There are still individuals, many individuals in the Part D program who aren't getting the benefit of all of these programs on a regular basis. So again, room to improve and drive more of the really excellent findings that the two studies Susanna called out.
Yeah, just to put a number behind that, in CMS's 2023 star ratings, it's documented that 54% of standalone PDP MTM enrollees and 83% of Medicare Advantage MTM enrollees received that comprehensive medication review that I discussed. So again, as Heather said, there's room to get that up to 100% in each population and to reach more patients.
Great. Okay, let's move on to our last polling question before we talk about formulary design. So what is your familiarity with formulary design? None, some, and very experienced. Okay, so it looks like most people are familiar, and probably some of you sit on some of the committees I'll talk about involved in formulary design. Okay, so formulary design or formulary is a list of drugs covered by a particular prescription drug benefit, and those are organized by therapeutic area or treatment area. So for example, antivirals or immunosuppressants, etc. And most formularies are tiered, where the lowest tier is corresponding to the lowest member out-of-pocket costs to encourage members to take therapeutically appropriate medications at the lowest cost to themselves and to the plan. Typically, generics are on the lowest tier, followed by preferred brands on the next tier, and then preferred specialty on the highest tier, and then including, I guess, covered drugs are that are non-preferred on the top tier, which would result in the highest cost to the member. Formularies typically do identify drugs that are excluded from coverage, and they call out those drugs that are covered on the formulary that are subject to some of the things we've talked about, such as prior authorizations, step therapy requirements, and quantity limits. And so the goal of a well-designed formulary is to promote clinically sound, cost-effective care that results in positive therapeutic outcomes. But the process to develop formularies is very complex and very involved. It is evidence-based, and it really, on average, involves the input from three key groups. So the first group is the internal clinical review team. And that team's comprised of physicians and pharmacists and other healthcare professionals that are typically employed by the health plan. And what they do is collect and synthesize information about products that are under review. So as Susanna mentioned, as new products come on market or a new indication is approved by the FDA for a product, then those products will pop up as eligible for collection of information by this clinical review team. The clinical review team passes on their information to the next group, the Pharmacy and Therapeutics Committee, or P&T Committee. That group is also composed of physicians, pharmacists, and healthcare professionals. Their job is really to review the information provided by the clinical review team and to vote on whether or not to approve or deny a product for inclusion or exclusion on the plan's formulary. But the process doesn't stop there. The final group involved is the value committee, and they're tasked with evaluating the cost effectiveness of a therapy and negotiating its cost. So that team is typically made up of healthcare professionals, but also data analysts, financial analysts, and stakeholders that are focused on ensuring a balance between medication access and controlling costs. Now, often the health plans or the PBMs will implement a firewall between these three teams to really make sure that the business influences are limited between the teams in terms of clinical decision making. Now, the value committee will certainly consider net costs, and one of the things they're certainly looking at is the gross cost or the list price of products, but also the rebates that can be achieved through manufacturer negotiations, which lower the cost of the product to the plan, and in some cases to the member directly. So on a more restrictive formulary, for example, if the P&T committee independently decides that, let's say, 2 medications are equally effective and appropriate for the majority of patients with a particular condition, and then the value committee looks at costs, the committee may choose to cover the less expensive product at the exclusion of the alternative product to help control cost and steer patients to the lower cost alternative. So just looking at some of the bullets on our slide here, the AAM, Association for Accessible Medicines, did an interesting study in 2021 where they calculated that the generic use in the US has saved $373 billion in costs in that year, and that's across all payers. And that calculation was done as the cost of the generic compared to the alternative taking a branded product. And so that cost savings is almost as much as the country spent in total in prescription drugs in 2021. And another study by CVS Caremark estimated that those clients that align themselves to the company's template formularies or national formularies, which are more restrictive, they will save about $4.3 billion in 2023 compared to our clients that go with a more open formulary with fewer or no exclusions. So again, real savings and value driven through a well-organized formulary. On the right of our slide, we did also want to look at generic utilization across different types of plans. And as you can see, all of the commercial to Medicaid, all of these payer types are achieving generic utilization in the high 80s to low 90s. But I did want to call out managed Medicaid at 92.5% generic utilization. Those 3 percentage points higher than fee-for-service is really one of the value drivers of managed care. And given the volume of products that are dispensed in generic form, those savings in that 3% is significant. And I think that's why, one of the reasons why we're seeing more and more Medicaid lives move to the managed care setting. Okay, so next, why don't we move on to talking about some of the research around Medicaid. So I'll start us off, and Susanna will dive into some of the details of our independent analysis that we did in putting together this report for AMCP. So we worked with the Medicaid utilization data, and we focused on differences between fee-for-service Medicaid plans and managed Medicaid plans, specifically looking at the hepatitis C class of drugs. And we looked at those products that came to market in 2013 that were really cures for hep C. So we didn't look at the ones that had been on the market in terms of management of hep C before, as those were ultimately discontinued. So we're really focused on those cure products. And a number of products came to market, as we might all recall, in 2013. They were very expensive. It was a big development in the industry. and then more and more products followed suit over time. So we segregated fee-for-service plans from managed Medicaid plans. And as Susanna noted earlier, the volume of individuals in managed Medicaid plans has grown from somewhere in the mid 50% back in 2013 to up to 75% today, with maybe up to 85% if you consider some form of managed care. So the bar graphs here demonstrate the total spend by fee-for-service Medicaid over that 2013 to 2022 period, so the $7.3 billion, versus the total spend in managed Medicaid of $11.7 billion. And obviously those spending rates relate to a different number of units. But if we did just some simple math with these aggregate numbers, we would find that over the whole period, managed Medicaid spent about $80 less per unit than fee-for-service spent. But I'll turn it over to Susanna now to really get into some of the nuances of what we found.
Great. Okay, so what you're looking at on the chart is a line for managed care, the orange line, and a line for fee-for-service, the blue line, that looks at the yearly average reimbursement per unit for hepatitis C drugs in each program. And so you can see that fee-for-service and managed Medicaid start out very closely aligned. The lines are effectively on top of one another in 2013, 2014, 2015, and even into 2016. But in 2017, we really start to see that managed care line diverge from the fee-for-service line and to decline significantly, where we're seeing managed care just reimbursing pharmacies much less per unit for hepatitis C drugs than was happening with the fee-for-service program. And so it's important to note as we talk about this analysis that we're looking at pharmacy reimbursement rates. This does not take into account rebates, although we'll talk about how rebates may impact this analysis. We think managed care plans are still achieving savings, even if you look at things net of rebates. But for purposes of this analysis and working with the Medicaid utilization data, which doesn't reflect rebates, everything here is in terms of gross spending. But you can see that managed care is doing something different starting in 2017 that's driving that line down. And if we look at that gray box highlighting 2017 to 2021, which is when we see those reimbursement rates are really different between the two programs, if you were to translate that into savings, managed care realized a pre-rebate savings of almost $1.5 billion on all of their hepatitis C utilizations compared with fee-for-service. And said another way, if fee-for-service plans had been able to achieve that same reimbursement rate that managed care plans were achieving, they would have spent $780 million less on hepatitis C therapies during this time period. So on the next slide, we're going to dig into what was driving these differences in reimbursement rates. Okay, so as we started to examine what was happening here, we discovered that it wasn't a difference in how much fee-for-service was paying the pharmacy versus what managed care was paying the pharmacy for the same products. Those reimbursement rates are really quite similar. What's driving the savings in managed care is their product mix and their ability to steer patients to lower priced products sooner than fee-for-service was able to. And while the Medicaid utilization data we rely on doesn't contain information about preferred drug lists, patient cost share setup, step therapy, or prior authorization, all of these tools that we've been discussing, we do think it's reasonable to conclude that the significant savings that they're achieving and their ability to steer patients to these lower priced products sooner than fee-for-service is a result of those tools at work. And so I won't go through every year here, but I'll start with 2017 since that's the year where we really start to see those two lines diverge. And what's happening in 2017 is that you can see 38% of managed care's utilization is on a product called Zapatier that has an average reimbursement amount of around $645 per unit that year. And if you look at fee-for-service, only 16% of their utilization is on that lower priced product, with much of the remaining fee-for-service utilization still on that yellow bar Harvoni, which is over $1,000 per unit. So what we see in 2017 is managed Medicaid has moved more individuals onto Zapatier with its lower price tag, whereas fee-for-service still has much of their covered lives on Harvoni, which is much more expensive. And so if you look across that product mix, that's really creating significant gross price savings in the managed care program. I'll look at one other year. In 2019, managed Medicaid is successfully shifting more utilization to a generic, an authorized generic that enters the market, sofosbuvir velpatasvir. 28% of managed Medicaid utilization is on that product versus only 7%. We're looking at the green line in 2019 versus only 7% of fee-for-service utilization. And that product costs on average $277 per unit. So again, that's a really significant reduction in price versus some of these products that cost over $1,000 per unit. And managed Medicaid has quickly steered their patient population to that lower priced product, and it has a really significant impact. By 2022, you kind of see the programs converge to one another a bit more, and their product mix is much more similar at that point. And if you were to look back at the prior slide, you'd also see that the reimbursement lines start to converge again in 2022, but it took fee-for-service longer to get to that point. Now, I've noted that this is a gross price analysis. It doesn't reflect the impact of rebates, but other researchers have looked into managed care savings on a post-rebate, net price basis, and have found that managed care plans achieve significant savings versus fee-for-service. So the Menges group did a study for AHIP that found that the net costs per prescription in Medicaid managed care were 27% lower than fee-for-service, yielding $6.5 billion of savings in federal fiscal year 2018. Another study, also by the Menges group, found that managed care organizations were achieving much more favorable initial, i.e. pre-rebate costs per prescription due to their management of the mix of drugs, particularly a much higher reliance on the use of generic medications. So that's, again, pre-rebate, but very consistent with exactly what we're seeing here, and with that higher generic utilization rate that Heather mentioned a couple slides ago of 92.5% in managed Medicaid versus 89.5% in fee-for-service Medicaid. That Menges study goes on to say that larger rebates in the fee-for-service setting do close much of this initial gap, but managed care plans are still achieving considerable net savings relative to fee-for-service. So we found that what we're seeing kind of at the pharmacy counter in terms of the mix of products being dispensed is very consistent with the goal of these managed care pharmacy tools, which is to get patients on the most cost-effective options available that are therapeutically appropriate, and to do so sooner rather than later. With that, I think we've gotten through our slides. I'll take a look and see if we've gotten any questions. I think we're going to turn it back to Tyler to moderate.
Well, thank you, Susanna and Heather, for the great presentation, and also thank you for your great work and research on the report. We have just about 5 minutes remaining in the hour, and I'd like to remind folks that you can use the Q&A function in the top right corner of your screen if you'd like to submit any questions. I'd also like to reiterate just how important and how great it is to have a central repository of data for information on the practice of managed care pharmacy, and how grateful we are for the creation of this report. I did have one question regarding the data sources you used in general. The examination of the prevalence of managed care pharmacy tools and their impact cites data from Medicare, Medicaid, and commercial plans. I was wondering if these findings were similar to what occurs in other managed care programs, such as the VA or TRICARE, or if that data is not as readily available.
Yeah, unfortunately, there is a lot less data available for those government-run programs. It's our expectation that many of the same tools are being implemented there, just through a different technique and approach through the VA and TRICARE, certainly through TRICARE, given that many of the commercial PBMs are absolutely involved in helping to run those programs. So we think the findings would be similar. There's just less robust data available, unfortunately.
Thank you, Heather. I do see one question that came in asking for a reminder about the title of the report. I can go ahead and take that one. The full title of the report is Access, Affordability, and Outcomes, the Value of Managed Care Pharmacy. And you can find that report directly on the welcome page of the AMCP website. It's also available in our resource center. And finally, it will also be included as a handout in this meeting handout packet. I'm not seeing any other questions coming through at this time. I would like to take a moment again to thank Heather Bates and Susanna Leaf for speaking today, and I'd like to thank BRG for providing this webinar, and thanking each of our attendees for joining us today. We'd encourage you to be sure to look out at our list of upcoming webinars at www.amcp.org/calendar. And this concludes today's program. Thank you.
Thank you.